Cash USMLE style question on Hydrocephalus Ex Vacuo. Question. A 72-year-old man is brought to the clinic by his daughter due to progressive memory loss and difficulty with daily activities over the past year. His daughter reports that he frequently forgets recent conversations, misplaces objects, and has trouble managing his finances. Neurologic examination reveals disorientation to time and place, impaired short-term memory, and difficulty performing simple calculations. Motor function and gait are normal. MRI of the brain shows enlarged ventricles with cortical atrophy, but there are no signs of increased intracranial pressure. Which of the following is the most likely cause of this patient's condition? A. Decreased CSF absorption at the arachnoid granulations. B. Excess CSF production by the choroid plexus. Structural blockage of CSF outflow within the ventricular system. D. Compensatory ventricular enlargement due to neuronal atrophy. E. Increased CSF pressure intermittently affecting the corona radiata. Compensatory ventricular enlargement due to neuronal atrophy. Explanation. This patient presents with progressive memory loss and cognitive impairment, which is highly suggestive of Alzheimer's disease or another neurodegenerative disorder. His MRI findings of enlarged ventricles with cortical atrophy and the absence of increased intracranial pressure, ICP, are consistent with Hydrocephalus Ex Vacuo. Key features of Hydrocephalus Ex Vacuo: caused by brain atrophy due to neurodegenerative diseases, e.g., Alzheimer's, Huntington's, HIV-associated dementia, appearance of increased CSF due to loss of brain tissue rather than true excess CSF production or obstruction, no symptoms of increased ICP, no headaches, nausea, or papilledema, irreversible and progressive. Imaging findings: enlarged ventricles, but with proportional cortical atrophy, no periventricular edema or signs of increased CSF pressure. Management: treat the underlying neurodegenerative disease, e.g., cholinesterase inhibitors for Alzheimer's. Why not the other options? A. Decreased CSF absorption at the arachnoid granulations, seen in communicating hydrocephalus, e.g., post-meningitis scarring, subarachnoid hemorrhage, which would cause symmetrically enlarged ventricles and increased ICP symptoms, headache, nausea, papilledema. B. Excess CSF production by the choroid plexus, seen in choroid plexus papilloma, which causes communicating hydrocephalus and increased ICP, not progressive neurodegeneration. C. Structural blockage of CSF outflow within the ventricular system, seen in non-communicating obstructive hydrocephalus, which would cause ventricular dilation upstream of the blockage and increased ICP. E. Increased CSF pressure intermittently affecting the corona radiata. Describes normal pressure hydrocephalus NPET, which presents with the triad of gait disturbance, urinary incontinence, and cognitive impairment, not isolated memory loss. Take-home point: Hydrocephalus ex vacuo occurs due to neuronal atrophy and brain volume loss, leading to compensatory ventricular enlargement without increased ICP. It is commonly seen in Alzheimer's disease, Huntington's disease, and HIV-associated dementia.